Hello, I'm Michael Pierce, and this is The Human Condition. Today, we're doing a clinical science explanation of a new product called the Achedaway cupper. In this episode, we're going to be exploring the mechanisms behind what kind of conditions can a product like this do and help with. This is the Achedaway cupper. It is a simple product that's very action-packed. The achedaway.com is the website, and I've been asked to explain how and what mechanisms and what conditions this might aid in helping. In the description below, you will find an affiliate link that we do benefit from, and that helps us keep our channel going for you to be able to purchase this product and other products by the company. Now, we can't talk about treating conditions directly with this because that's not how it works. All of alternative medicine nudges and helps things and provides supportive, adjunctive, and palliative care. So what we're talking about is this very sleek product, and it will not be a review of the product and how it works. There's plenty of those already. What we've been asked to do is explain the science behind how this particular set of features might affect conditions. And so we're going to talk about conditions and pathways together today. So this is what it looks like. It's a mechanical pump that's built on top of a cup. And the cup is not glass, it's very safe, and there are red lights inside it. That array of red lights shines a 630 to 670 nanometer, which is red light, not laser light, but LED light onto the skin. And we're going to explain today the different conditions and different types of conditions that this can help with and how it can help. We're going to be exploring essentially visceral conditions, which is to say chronic conditions in the trunk and abdomen, which are things like anything that would affect your pancreas or your heart or your liver, things like chronic diabetes, things like chronic heart conditions, things like chronic liver conditions, chronic lung conditions, chronic kidney conditions. And there's a lot of those. We're not here to say that it's going to cure or treat any of them. We're here to say that it would provide supportive care for them because there are some powerful mechanisms by which it might do that. We're also going to talk about the brain and how different chronic brain conditions and mental health conditions might actually respond and benefit from this kind of cupping method that's cupping plus. It's not just cupping. We're also going to be explaining the mechanisms, and the mechanisms are a lot. We have a lot to unpack today. We're going to be looking at 4 neurological mechanisms. We're going to be looking at 2 biochemical mechanisms, and we're going to be explaining the difference between different mechanoreceptors and proprioceptors that pick up these messages from the Ruffini's fibers to the Merkel's discs in the skin. We're going to be talking about where those relays affect the brain and spinal cord all the way up. And we're going to be talking about the effects of growth factors that are made by cupping when cupping causes that bruising effect that gives us that purplish dome that pops up when you do cupping. And we'll also be explaining a little bit about how the mitochondria are affected by the red light of this system. So it's really exciting, and I can't wait to dig into it. It's a fairly long and complex one, but I think you'll really enjoy it. You may have studied cupping in Chinese medicine, where they take a glass cup and they put a flame into it to heat it up, and then they stick it on your skin after there's been some oil on your skin, and it's allowed to be moved around, and it causes a great deal of suction. And that suction pulls the skin up into the cup and allows for a bit of bruising to occur. This bruising happens, and then the practitioner moves the cup around to another spot, and then ultimately you have these suction cup marks that are harmless and therapeutic all over your back. When this product comes along, it adds a few things to the old ancient cupping method. It adds, number 1, a motor. There's an electric motor with a switch that has 5 different settings that allows the practitioner or the individual to have different levels of suction. And there's also different lengths of time that the device can be sucked onto the person's body before it turns off. In addition, there's a really cool array of red lights that are therapeutic in here that shine red light at the skin in a range of 630 to 670 nanometers, which is a red light range, which is perfect for stimulating mitochondria, which we'll get to in a bit longer about how it heals. This device can be hooked up to a smartphone with an app that allows you to hook up to 6 devices, up to 6 of these together in an array on your back or somebody else's back, to be able to use them as a group like they're used in Chinese medicine. They use more than one at a time most of the time, and a nice lanyard so that you can hang on to it if you're doing it by yourself. So that's the device. Quite simple, quite sanitary. and it comes with some cotton filters for suction, because certainly this machine will suck air through it. And there's these 3 cotton rings that are given to you for reusable cleaning or disposable use that go back inside the machine underneath the cup. The idea of cupping is a simple one, but its application in science today is very complex. So we're going to try to unpack what happens metabolically and neurologically when a clinician uses something like this kind of device. When an application of a cup is put on the skin, it sucks the skin up and it makes a dome of skin, and it breaks little capillaries, and there is formed a purplish bruise. That purplish bruise is a defined area, and every time they move the suction, there will be more bruising that occurs both in the track between the positions, which is just a little bit, and much more on where the cup is left to sit for a few minutes. And a practitioner may move the cup around several times during a session, and this is usually done during an acupuncture or Chinese medicine section. And let me say that I don't have training in Chinese medicine. What I was asked to do is explain the science of clinical applications of these devices, which fits right in with chiropractic and natural medicine, and I want to support with Western medicine the science of my brothers and sisters in TCM, or traditional Chinese medicine, which is traditional Oriental medicine, however that is said these days. The Asian medicine systems involve the use of qi and the movement of qi and the rearranging and reorganizing of patterns of energy through the body that are on meridians. Now, while I'm not an expert at that, what I'd like to talk about today is some of the Western science of what happens in the neurology as well as the metabolism with devices like this, and this is a really exciting option for someone to use, and you can use it on yourself. It's very safe, it's very reliable, and I've had very good luck using this and playing with it. It's so much fun. With the first step we want to talk about is whenever a device sucks on the skin and changes the skin, it fires a set of neurons in the body that are proprioceptive neurons. Those neurons are of a couple of different types. Some of them detect deformations in the skin that are unchanging, like steady pressure or steady heat or any kind of steady state. Other types of neurons only detect the change. They detect the change, and once things aren't changing anymore, they stop reporting to the brain. So we have these different kinds of fibers, and they fire in a pathway that's called the mechanoreceptive or proprioceptive pathway. And that pathway is a large set of pathways in the spinal cord and brain. Those are things that fire pressure changes of long-standing pressure, and long-standing pressure that is unchanging over time is fired by Ruffini's fibers. And these Ruffini's fibers are deep structures that are inside the skin, and they perceive constant unchanging pressure or suction. They also send that signal up to the spinal cord, where it enters the spinal cord and kind of gets on an on-ramp of neurology. It's an on-ramp that goes into the spinal cord and then ascends up to the brain and ultimately goes through the thalamus and to the parietal lobe, usually on the opposite side of where the sensation is. So if the sensation's on the left side of the body, it ends up on the right side of the brain in the parietal lobe. Another set of cells that are called Merkel's discs, and Merkel's discs detect the shape of something that you might sit on. So for example, if I were sitting on a stool or a stone bench that had a bunch of masonry in it that was built with a bunch of triangles, my butt could feel the shape of the triangles when I sit down. On the other hand, if there was a stone shape that had circles or that had squares, I could tell you with my eyes blindfolded and my hands clasped behind my back with my own skin cells on my butt, I could tell you that it was square-shaped or circle-shaped or triangle-shaped just by feeling that action. So that's called proprioception or mechanoreception, which is the feeling of what's going on in your skin. Now, most of us are more familiar with mechanoreception and proprioception coming from the cells that are in your joints and in your feet and in your spine and in your muscles that tell you about rate of change of length of muscle spindles. They're structures that tell you about pressure and movement in your joints and in forces in your joints about, for example, how much pressure is on one side of your body versus the other side of your body, in your spinal joints, in your feet, in your hips. And all of that tells you about how you're moving, tells your brain about how you're moving or how you're sitting still. In this case, we're looking at skin proprioceptors and skin discriminative receptors that tell you what's going on the surface of your skin. The value of this is incredible. The value of being able to know and feel, both consciously and subconsciously, what's going on in your skin is incredibly important. And the reason for that is that humans are built with massive amounts of nociceptors or pain receptors that constantly fire below our level of consciousness. And part of the reason for that is we've got 4 different levels of inhibition of pain and inflammation that happen in our bodies. So if you can imagine us, we're wired and designed such that constantly there's signals from all over our body that are reporting the death of cells, the chemical overcoming of cells, the cells that are dying and winking out and falling apart before they get repaired or replaced in our bodies, and they send a signal of pain that would go to our brain, and we would perceive that normally as ouch. And it's all over our body and it's constant. The cool thing about gravity is that when we move around in a field of gravity, we have constant pressure on us from gravity and we resist it. And as we resist that gravity, our muscles fire and our pressure receptors fire and our joints fire and our cartilage fires, our bones fire. Everything that has a nerve cell in it fires to our brain and says, there's pressure, there's movement, there's change, there's skin tactile sensations, there's cold, there's all kinds of stuff happening. And any of that is considered proprioceptive or mechanoreceptive goes into the spinal cord, and at 4 different places in your nervous system, that inhibits pain. And so the first of those that these Ruffini's fibers in your skin and these Merkel's discs fibers in your skin do is they go into your spinal cord. And in the spinal cord, there's something really exciting that happens for chiropractors, and that is the idea that mechanoreception goes into these cells that activate something called the pain gate, and this is called the gate theory of pain. It's using something called wide dynamic range neurons, and these are nerve cells that inhibit inflammatory cells. They inhibit chemicals that are inflammatory in the spinal cord at each cord level where they enter. They inhibit nociception and pain that comes in. They inhibit an outgoing message of spasticity. They inhibit blood vessel activation of excessive sympathetic activation. So there's a lot of stuff that goes on in the spinal cord at whatever level of entry the cupping comes into. So if you're doing cupping on your body from, say, your collar line down to your waistline or your upper butt, which is pretty much where a Chinese practitioner will put these cups, or a chiropractor might put these cups, is all along your back, you're going to be having sensory signals, proprioceptive signals, entering your spinal cord at every cord level from about T1 down to the sacral cord levels that are down at the bottom of your spine and the top of your pelvis. So you'll have a massive barrage of proprioceptive, mechanoreceptive information that comes from the pressure changes that happen from the actual pressure on Ruffini's fibers, and you'll have shape receptors that will determine shape of the cup and the shape of the rim all around that edge from Merkel's discs. And they will go into the spinal cord, and at every level, from the T1 level down to the S1 level or the other levels, depending on how far down the therapist puts the cups, you'll have this massive amount of information that every single cord level is receiving, so that any cord level that's inflamed or that has pain or that has spasm or that has hypersympathetic tone, too much sympathetic dominance, too much problems with controlling blood vessels, will be inhibited or normalized. Now, that is exciting for us because imagine what is between T1 and S1 in your spinal cord. Every visceral organ in your body, except your brain, is supplied by that. So that means your lungs, your heart, your pancreas, your liver, your gallbladder, all of your digestive tract, some of your pelvic floor, but not all, most of your digestive tract, all of your viscera, all of your ability to drain the fluids in your abdominal cavity and your chest cavity. All of those are under the control of sympathetic nerves that leave the spinal cord and are modulated by incoming mechanoreceptive signals. So if we can give a passive mechanoreceptive signal to a person while they sit on a table for a period of time, that's very exciting. And the very cool thing is, because these bruises can last a couple of weeks afterwards, we still have a change and a difference in firing of those neurons around those circular marks for weeks. So we get the effect that's certainly larger during the time that the person has the cups on them, which may be 10, 15, 20 minutes or less, as well as the after effect that is somewhat less, but will still be there for 2 weeks afterwards while those bruises heal. So from a neurological perspective, we've got the incoming mechanoreceptive signal that essentially blocks pain signals and blocks inflammatory signals and blocks neurochemical signals and blocks aberrant blood vessel constriction sympathetic signals and controls them and modulates them. But I told you there were 4 different levels that happen when mechanoreception enters the central nervous system. We talked about the first on the way up. That was the spinal cord level. The next one is at the brainstem level. This is in the midbrain, the mesencephalon, and it's called the periaqueductal gray. When this information ascends and hits the periaqueductal gray, there are some collateral fibers that tell the periaqueductal gray to send descending pain inhibition down the spinal cord to inhibit pain in the spinal cord that may be ascending. So we've got, let's just review, we've got the entering levels that are at all the individual cord levels from T1, T2, T3, T4. These are thoracic 1, 2, 3, 4, all the way down through the lumbars that go all the way through this system. Every one of those gets an inhibitory signal that modulates and regulates too much sympathetic outflow, too much inflammatory chemistry, too much pain incoming. Then we've got the periaqueductal gray that happens in the mesencephalon and the brainstem. Once we get into the brain and the head, then we have the thalamus. And this pathway will go through the VPL, or ventral posterolateral nucleus of the thalamus, where it hits the thalamus and it begins to inhibit pain signals throughout the body, because the thalamus is a major sensory transducer. It's a major sensory relay station. And mechanoreception in the thalamus tends to inhibit pain throughout the thalamus and throughout the brain. So there'll be a massive inhibition of pain happening in the thalamus. So we've got spinal cord level multiples. We've got the periaqueductal gray, or PAG, which is inhibitory descending fibers that are in the mesencephalon, or the midbrain of your brainstem. We've got the thalamus, which will inhibit pain. And then when we finally make it up to the brain, we get to the parietal lobe. The magic of mechanoreception or proprioception hitting the parietal lobe is the idea that the parietal lobe also has collateral pain inhibition from mechanoreception. And more importantly, about 1/3 of activation of the frontal lobe comes from the parietal lobe. So if the parietal lobe is activated by mechanoreception, we get better activation of our frontal lobe. And who doesn't want better activation of their frontal lobes? That's what makes us human. That's what separates us from other organisms. So now we've got the 4 mechanisms neurologically where inhibition can happen. What does this mean for the treatment of disease and illness? Well, alternative medicine doesn't treat disease directly or cause cures or treatments according to the law. In the United States, we have to be very careful because you can't say cure, diagnose, treat any illness with these natural and alternative methods, which are, in a sense, considered experimental by our law. Now, these traditions may be years old. The Aborigines used methods that were 25,000 years old. In India and China used information that was Ayurveda 7,000 years old, traditional Chinese medicine 3,000 to 5,000 years old, and traditions like chiropractic are over 100 years old. So there's all kinds of stuff that's been around for a long time, and we've used it to treat people, but we can't say that in today's environment of the FDA and the FTC, we can't say that they are to treat a disease. However, if you had something like diabetes, which is a disease of the pancreas, or you had a heart disease, or you had a lung disease, or you had some other chronic condition, wouldn't it be nice if you could modulate the output of the spinal cord and the brain to have a better control and better dynamic range of that set of cells? It would be nice because organs like the pancreas, and there's lots of articles on this in Science, organs like the pancreas do have a sensory component, which we call sensory, but it's not really sensory, because sensory is considered conscious. I'm going to talk now a little more specific about neurology. They're afferent signals. Afferent signals are signals that go from tissue to the brain or to the central nervous system for information, for input, and they're not necessarily conscious. So we're not going to call them sensory because you're not aware of them. How many of you are aware of your pancreas right now? How many of you are aware of your glucagon or insulin production? Not very many. How many of you are aware of the bile production that your pancreas is making right now? Not many of us. So that's not conscious, so we don't call it sensory. So to be strict, we have this afferent or incoming input from the pancreas, and if we want that incoming information from a swollen and inflamed pancreas from having diabetes and from having insulin resistance and from having bad diets and all the different things that we do to ourselves, if we want to modulate that, One of the ways we might do that is with proprioception, and that is done with things like cupping. If cupping is done, cupping will decrease the probability that there will be bad sensory input going into the spinal cord from any given organ. So whether it's diabetes, whether it's heart disease, whether it's chronic lung disease and COPD, whether it is a chronic fatty liver, any type of visceral inflammation, any type of visceral problem could benefit in a supportive, adjunctive, or palliative way without being considered a treatment. So don't run off and say, oh, Dr. Pierce said we could treat pancreatitis or diabetes with a cup. That's not what I'm saying, and that's not the truth. What I'm saying is that we want every force, every factor we can that gives us odds to increase toward helping that organ. So any visceral complaint could benefit in some small or large way from proprioception. That would be digestive complaints, which are huge. We have people that have digestive complaints all the time that talk about indigestion. They talk about stool problems. They talk about burping and belching. They talk about pain and GERD, gastroesophageal reflux disease. We also talk about patients that have menstrual problems. They have menstrual problems and they need to have control of that set of reflex inflammation. That can happen in the spinal cord. It can happen in the brainstem. It can happen in the thalamus. It can happen in the parietal lobe. The parietal lobe is filled with receptors for our guts. There's an area in the parietal and other lobes called the insula. The parietotemporal insula is the area in which you feel your guts. And if you have much proprioceptive or mechanoreceptive information coming into your brain, you can effectively inhibit bad signals coming from your guts. You can turn down the alarm in your brain that comes from those guts, and you can reduce some of the misfiring of the brain from that. So this is all information that there is solid science on the mechanisms of how it works, but we can't make claims about whether it can treat a condition in today's environment. I hope if you read this and look these things up online with PubMed and you look up mechanisms, and I can do this at another time, but there are tremendous papers on the mechanisms of how this works. These mechanisms are well known, and so there are doctors that do these methods, and that's one method, the way this works. Let's move on to the red lights. The red lights are 630 to 670 nanometers, which is a red visual light. That red visual light is something that can stimulate things called mitochondria. Mitochondria are in every cell of our body. Their DNA comes from our mothers exclusively. We don't get any mitochondrial DNA from our fathers. And they are instructed to produce energy in our body. They are essentially the fuel cells of our body. If you've studied fuel cells, if you've studied how fuel cells and electric cars and fuel cells work, if you understand how hydrogen ions and electrons work when they are fuel cells, that is the original fuel cell. It is in our own bodies already. And so mitochondria essentially help to transfer electrons around through something called the electron transport system. And the ETS, or electron transport system, consists of 5 big floating islands that are in the surface, embedded in the surface of mitochondria, which are inside all of our cells. And these mitochondria have this electron transport system with these 5 floating systems. And what they do is they essentially trade electrons and oxygen and hydrogen and make this ATP, which is adenosine triphosphate. It's a molecule of energy. And essentially, what it does is it forms a bond that can be broken and passed around. So once this bond is formed with phosphorus, this ATP molecule can send more energy around. So whenever red light is used in therapy, and there's red lights right in here in this array on the inside, those red lights shine onto skin and they can activate the electron transport system and stimulate cytochrome C, among other molecules that happen inside this electron transport system in these 5 different passageways that give this energy production inside the body. So they stimulate healing, they stimulate the process of wound healing, and they stimulate the production of energy throughout the body to help a person heal and get better. And it's something that is easily stimulated in the body. Another method that is really interesting about the way a cup works is that when a cup causes a bruise, we are essentially creating what we would call poor man's PRP. Now let me unpack poor man's PRP. Platelet-rich plasma is a procedure that's done in medicine today where they extract some of your blood, some of your plasma, and they spin it down so they can get your plasma and separate it from the cells. So they separate with a centrifuge your cells from your plasma. And it turns out that you can extract some pretty cool growth factors and some very exciting chemicals that are in your blood and then re-inject that plasma back into your body. It's done by doctors, and they inject it into your joints, they inject it into your skin, they inject it into different places, and it has varying levels of technical expertise, and it's a kind of a neat new experimental thing that's being done. The idea of poor man's PRP is that when a person bruises and you see all those purplish swellings along their back that look like an octopus grabbed them and sucked on them and left their mark, those purplish bruises have this material that is the filtrate, or the filtered out material that's partially filtered, not completely filtered. I'm not saying that these wounds are the same thing as PRP, but there's a lot of similarity because we have platelets that have been brought to the area, we have the release of serotonin, which is in platelets, we have the release of the same growth factors, and so in a sense what a person's done is created these little islands of platelet-rich plasma in their back, wherever these little wounds have occurred. And they're trivial wounds. For most people, they're safe. Certainly there are people that should not do cupping. But for those people that have done this, they're essentially getting the same types of chemicals and releases of growth factors that are released by PRP. Now, this is not the same thing. Don't go away and say that Dr. Pierce said that cupping is the same thing as PRP. It's not. But there are some similarities, and the chemistry would be crazy for me not to talk about. So what have we looked at so far? We've looked at 4 levels of neurological involvement with 2 kinds of fibers, Ruffini's fibers and Merkel's discs. We've looked at that mechanoreceptive pathway that goes into the spinal cord at every level where the cups are placed, that inhibits at the spinal cord level the sympathetic activation if it's excessive, the inflammatory modulators that are released at the spinal cord, and pain signals that are present entering the spinal cord. We can inhibit them with the pain gate. We went up to the brainstem. We went up to the brainstem and looked at the periaqueductal gray, which sends descending fibers down that inhibit pain fibers that are on their way up. That's up in the mesencephalon, or the midbrain, at the top of your brainstem. Then we went up to the thalamus inside the brain, and we said that the thalamus would have inhibitory action to reduce pain through some pathways that are a little complex and I won't explain today, but essentially the thalamus inhibits pain and decides what we're going to pay attention to and what we're going to ignore. And then we went over to the parietal lobe, where we said that the parietal lobe would be part of the brain right up here. The parietal lobe is here, the frontal lobe is here, the temporal lobe is here, and the occipital lobe is back here. We said that the parietal lobe, which is where we sense touch, which is where we sense in the parietal insula, which is a pocket. The insula is a fold inside your brain where you sense your guts. If you've ever sensed a gut feeling that's not so good, or you're about to vomit, or you feel bad sensations in your gut, you're perceiving that in your parieto-temporal insula, which is right over here. If you get a bunch of proprioceptive or mechanoreceptive barrage of information coming from your skin, from your joints, goes up into your brain, goes up into your parietal lobe, and it can help inhibit those types of fibers. So it can help a person with chronic illness, even terminal illness sometimes, have a more comfortable life, if not save them or help them. Because there are benefits to this type of medicine, even in terminal illnesses where we can't fix somebody, but we can help them be more comfortable as their life ends. But in most cases, we're not talking about the ending of life. We're talking about helping chronic conditions get better, and we're trying to increase the odds that neurologically we can inhibit some of these factors and get over them, provided you treat the original problem, which whatever organ is suffering needs to be supported and treated and made well. You're not going to fix an organ by neurological input exclusively if the organ itself is suffering. So we've been through red lights, we've been through 4 neurological levels, we've talked about the chemical actions of poor man's PRP. I want to mention that this is very similar to the way that families might buy a compression blanket or a compression shirt for their dog, or they might wear compression clothing to help them with anxiety or with ADHD. There are certain animals and humans that are given compression clothing for a number of neurological conditions for the same reasons that I'm describing. Because of the effects on the parietal lobe, because of the effects on the spinal cord and the brainstem and the thalamus, these are useful, and this is a very similar mechanism to the mechanism of wearing a compression shirt. You might also know people that wear a weighted blanket. They buy a leaded or weighted blanket and they wear that blanket at night, or they wear it on the couch when they watch TV, and that weighted blanket sits on them and rests on them and puts constant pressure on their skin. that will fire Ruffini's fibers, and the edges will fire Merkel's discs. Constant steady pressure that's unchanging will fire Ruffini's fibers, and Merkel's disc will be fired wherever there's an edge that's perceived. What kind of conditions might cupping benefit patient or an individual or a non-patient, somebody that's just looking for wellness? Well, really, any condition that's chronic organ involvement, whether it's even terminal and untreatable, or whether it's just a everyday reversible lifestyle illness like diabetes or like chronic obstructive pulmonary disease or GERD or digestive problems, any type of illness, we can increase the odds of helping that person by giving them a better diet, by giving them more exercise, by giving them better sleep, and by giving them a barrage of mechanoreceptive or proprioceptive input through cupping. And so that idea could be effective for a lot of conditions that are visceral, and I just named a bunch of them. There's a lot of research on the pancreas, for example, and really every organ, but the pancreas, for example, you'll see that afferentation or input that goes into, that's like sensory input but not conscious, that goes into the spinal cord and brain from the pancreas can be modulated by mechanoreceptive input. It can be modulated by proprioceptive input. Inflammatory output of the spinal cord from chronic irritation from an organ that's diseased or that is chronically ill can be dampened by mechanoreceptive input. That's why chiropractors adjust the spine near the cord level that corresponds with that organ, and that's not voodoo, that's neuroscience. We also would cup the same cord level. So if I had a problem with a chronic organ, I would try to find what cord level innervates that organ, and I would try to place the cups nearest to that organ. Now, does that say I'm going to successfully treat the disease? No. We're not talking about tit-for-tat treatment for a disease. We're talking about supportive adjunctive care. We're talking about nudging the body. We're talking about increasing the odds to make the person lean towards getting better. Can we measure exactly how much it helps them like we can in drug studies? No, we don't have the technology for that yet. But we can increase the odds, and the research science behind how these mechanisms work is very solid, although we can't make claims. I also want to mention that when you've seen the pressure work that happens when a baby is swaddled in clothes, when you wrap an infant in clothes and they're very tight, one of the things you'll notice is that cultures all around the world do this, and they end at a certain age, but at below a certain age, babies do very, very well when they're swaddled for a period of time. You don't swaddle them for 24 hours, you certainly let them be free, but during the time they're swaddled, what happens? They get calmer, they get sleepy, they get quiet, they get reserved, they don't have the same anxiety, the same crying, the same problems, because of this constant pressure. When the baby is swaddled, they have constant unchanging pressure, and that activates Ruffini's fibers throughout their bodies. Those Ruffini's fibers throughout their bodies will send a barrage of signal as long as they're swaddled all the way up to their brain and to their parietal lobe and help them grow and advance. And that, once again, remember that a third of firing of the frontal lobe is borrowed by voltage that comes from the parietal lobe. So if the parietal lobe is kept active, it will nudge the frontal lobe to stay strong. And we want that in development. We want that in childhood development as well as in adults. So these types of ways that activate the parietal lobe would be wonderful to get that parietal lobe going and get that frontal lobe going. Now, some of you that are super smart are going to say, wait a minute, Dr. Pierce, Ruffini's fibers respond to constant pressure. That's positive pressure. That is the pressure of gravity. That is the pressure of the atmosphere. It would get more pressure below sea level. It would get less pressure on Ruffini's fibers if you were at high altitude. If we put suction on a person, aren't we causing negative pressure? And aren't we going to cause a reduction in Ruffini's fibers? Well, maybe. However, there's a border around that cup where there is tremendous pressure. And that is where you'll have increased firing of Ruffini's fibers, even if you have decreased firing in the middle. In addition, Merkel's discs will fire massively because Merkel's discs will detect the edge. Merkel's discs fire when the edge is involved, especially when that edge is moved across the person's back, because remember, there's a lubricant oil or lotion that's put on the person's back in order to move these cups around. Every time you move the cups around, you make a massive barrage of Merkel's discs firing. So the person will have all kinds of inputs that mimic some of the mechanisms that we use culturally all the time. We've used cupping for centuries. We've used swaddling for millennia. We've used weighted blankets and the weight of people and dogs and animals, companion animals, lay on us and have done for centuries, eons, millennia. and the idea of compression clothes, compression bandages. Humans have tightly wrapped wounds for eons and millennia. And that works not only to stop bleeding, but to cause compression, which helps healing, helps reduce inflammation, helps return lymphatic fluid to the heart. So this is something that, and of course there's advanced taping. This is very similar to the mechanisms that are used in osteopathy. There's a small branch of osteopathy that's very exciting, where they would do visceral manipulation. Chiropractors have done this as well as osteopathy, and when they're done manipulating the viscera, they wrap the viscera in gauze in a certain way that winds up and causes compression in a compression bandage to hold things in place. This has been done for uteruses that are out of place, or that problems with ileocecal valves, problems with other organs. So I'm just drawing comparisons because I want you to understand it's the same mechanism. It's the same neurological mechanism. So we've got neurological, we've got chemical, based on action of this poor man's PRP and growth factors that come from your plasma being separated out and made into a bruise. And we've got the red light that happens that stimulates mitochondria and the production of energy through the molecule ATP in the electron transport system, which is 5 different little messengers and islands that float in the skin, if you will, the surface of the mitochondria that live inside our cells. And that is the Achedaway cupper.